Welcome to the Orthomind podcast, powered by our team at FARIL. I'm Nate.
I'm Ronan.
I'm Sion.
Today, we're honored to be joined by Dr. John Kwon, Chief of the Mass General Brigham Foot and Ankle Service and Associate Professor of Orthopedic Surgery at Harvard Medical School. But perhaps the thing he's most known for among the people who train under him is his commitment to teaching. And that's exactly what we're here to talk about today. Dr. Kwon, thank you so much for being here.
Thanks for having me, guys.
To start off, Dr. Kwon, many people say that the best way to learn how to teach is to pay close attention to those who taught you. You've spoken before about your mentors during your training who are largely responsible for steering you towards foot and ankle, so I'd love to start there. When you think back to what they actually did as teachers, what was it specifically that made their guidance so effective?
Yeah, I think that we are largely guided by positive mentors throughout our lives, throughout our education. I do think that, but we learn from everybody, right? We learn from people who are great teachers, people who are maybe not so great teachers, and so I do think that you have to kind of learn from everybody that you interface with. During my training, I was really influenced by people like Chris Kyoto and other people who continue to be my mentors today. They're colleagues as well, but also mentors. And I think that one of the key things is someone taking interest in you, your well-being, and your education, right? A lot of residency training, at least kind of in the old paradigm, was watch how I do things and osmosis, right? But I think there's a big difference between that model and someone actively teaching you, right? Not only just about orthopedics, but how to be a good doctor, how to be a good person, kind of what life is like as an orthopedic surgeon, not just fixing bones, but all the other things that come with it.
Okay, yeah, it's kind of built off of that. How much of what a great mentor gives you is technical and how much of it is other intangible things?
Yeah, I mean, I would think that very little is technical, right? I mean, part of our job as educators, whether it's for the orthopedic residents or fellows, is to teach them how to be good surgeons, right? Not only technically, but also how to teach them how to take good care of patients, whether it's operatively, whether it's non-operative treatment, whether it's managing the difficult patient or the patient who has a bad outcome, right? These are all important in terms of being a physician and being a surgeon. So, while that's part of it, teaching the technical aspects of surgery, I think more of it is teaching all these other things that are probably more important than some of the technical aspects of surgery. My father was a GYN oncologist, and when I was young, for some reason, we didn't really talk about medicine, but for some reason, he asked me what I thought was the most important attribute of a surgeon. And so, which was a little bit weird because we didn't talk about medicine or surgery. And I didn't know. I was probably like 6 at that time. But his answer was judgment. And I think that is true. I don't think it's technical skill. So to answer your question, while that is part of what we do as training, I think there's much more than just that.
So, Dr. Kwon, thank you so much for joining us today. There's a moment in every surgeon's career where the dynamic flips, where you stop being the one primarily learning and where you start being the one mainly responsible for someone else's development. Where did this shift happen for you? What surprised you most about being on the other side of it?
Yeah, I think it's hard to define an exact time of when that switches. And I'm not so sure it's purely like a dichotomous thing, right? I mean, I've been in practice for I think about 16 or 17 years now. And even now, the residents, the fellows are teaching me things about orthopedics, not just about, Taylor Swift or whatever, stuff like that. They're teaching me things that they know about orthopedics. And so I don't think that ever changes. So I don't think it's a dichotomous thing that you are learning and being taught and then something switches where it's just completely the other way. I do think most surgeons go through a transition when they're early in their practice where they are uncomfortable saying, well, this is how I do it, right? Because they've only done it for a year or two. So really how they're doing it is how their mentors did it or how they were taught or whatnot, right? So there is this very palpable transition and I recognize this when I stop saying, this is how I was taught, and I say, this is how I do it, right? Because not only kind of the evidence-based reasons why we do things, but you start to build up your own anecdotal experience. So, I mean, you can say anecdotal experience is flawed in certain ways, but you build your own experience so that you can say, this is how I've seen things work. So I don't know exactly when that happens. I think it's different for different faculty, but I think it is a transition that most of us go through.
Thank you for mentioning that. I think that even if you're doing kind of responsible in both ways for a mentee learning that, how do you think the teaching style differs from like person to person? Because as you were mentioning, people previously you might say that, oh, I learned this from my mentor versus this is how I do it. How does that actually, in your experience, changed how people under you learn?
Yeah, I think the biggest shift, and this is just my thoughts and opinions, but in terms of educators in this realm of what we do, surgical training, teaching people how to be good doctors, I think the main shift that I've seen and I've thought a lot about was figuring out how the resident or the student learns best, figuring out their learning style. This was never something we ever thought about, right? Because the old model was follow me around, don't ask me questions, watch how I do things, and you will learn, right? There was very little consideration of what a trainee's learning style was, right? And it's not as simple as carrot or stick, but some respond very well to positive reinforcement, motivation, encouragement. And some trainees respond very well to a more kind of stressful learning style, quote unquote pimping, right? That's not my style, but people respond in different ways. So I think that is a kind of evolving thought amongst educators that we have to figure out the residents' learning style, right? They switch every couple of months; they're all different. And we have to figure out how to most effectively teach them foot and ankle, trauma, sports during that time that they're with us. So I think that that's kind of the biggest shift. What's the latest generation? It's not millennials because we blame everything on the millennials. But what's the generation?
Gen Alpha?
Yeah, Gen Alpha, I guess.
Gen Alpha?
Yeah.
Okay. So it's really easy for people of my generation or older to say it's a millennial thing, right? Because in certain ways, it is a different generational way of thinking, but also too, you can't generalize and say everybody is a certain way. But there is a difference in terms of, I think, how trainees are and how they respond to the different teaching methods now than in the past. And maybe because in the past there was more just kind of one style of teaching surgical residents.
Interesting. So you've trained others across a lot of different levels, medical students, residents, and fellows. When you're working with someone, what are you actually watching for that tells you whether they are going to become a great surgeon? And is it the same thing at every level, or does it shift depending on where they are training at?
Yeah, I think that's really hard to say. Because I think it comes back to trying to define what a great surgeon is, right? So if you start there, I guess I would define that as a surgeon who has really good outcomes. The patient satisfaction is high, the patients are doing well, right? That's probably fair, right? Doesn't matter if a surgeon is great technically, but his patients are doing poorly. So having good outcomes, good patient satisfaction. So if I try to answer your question in that way, I think it's more interpersonal. I wouldn't say intelligence or emotional intelligence. Maybe it's emotional intelligence, but the trainees on any level who do well are people who are very thoughtful and interact well with everyone else that they work with. It is clear as day when we have trainees, and I've been doing this long enough, where you can identify a trainee who's going to have a problem during their residency or during the fellowship. And it's usually because they have poor interactions with the nurses. Usually it's someone who is lower than them, quote unquote, right? In terms of, and you can tell that they're going to have problems just based on that. So I don't think it's necessarily kind of how smart people are, or I think there is something to people asking very thoughtful questions as opposed to just asking a question, right? That is something that gives you some insight. But I honestly think it's how they treat other people around them, because while going to medical school, completing residency, being a faculty somewhere, it's all very difficult. Probably, I would think, in my mind, the key predictor of success is people who are kind and treat other people well. It's kind of that simple.
Very true.
Maybe not that simple. That's a big part of it.
So, following up with the definition of a good surgeon, only taking into account the technical aspect of surgery, how do you know if you will become good at surgery if you have never done one? And how do you have to wait all those years in training to know if you're actually a good surgeon or not?
Yeah, I think that's tricky. Okay. I think it's tricky because, one, I do think judgment is one of the more important things in terms of taking care of patients. I think that, generally speaking, we overestimate how technically sound your fine motor skills, your dexterity needs to be a very good surgeon. I think we overvalue that, honestly. And as you guys may know, in terms of the residency interview process, some programs try to tease that out. They'll have people do little things with their hands or drill PVC pipes or do these things. And as you can imagine, the literature that's looked at that has shown that has very poor correlation with how they're going to be as surgeons, right? So I think that's pretty hard to suss out, because it's probably hard for us to measure dexterity, fine motor skills, but also too, how important is that for most of what we do, right? So I know I'm not necessarily giving you a clear answer, but I don't think I have a very clear answer of how to assess that.
Thank you. And what do you think is the best way to communicate feedback to a trainee? And what do you think is the best way for a trainee to respond to that feedback?
Yeah, and I think that this has changed too. I think traditionally, people who were in my position were uncomfortable giving feedback, and the perception was that the trainees didn't really want feedback. Okay, and maybe that was because how we did that sort of thing was very different, I think, in the past than how we do things now. So aside from some kind of formality to the process, for example, I did a case with Tommy. We did a couple ankle fractures yesterday. He has an app that he can send me a link that gives an evaluation on multiple different criteria as it relates to that case of how he did. Preparation, like prepping and draping, the technical aspects of surgery, the aftercare, like all these different domains I can grade him on. It takes me 10 seconds to do, and boom, he's got almost real-time feedback, right? And very specific feedback on that one thing that he did that day, or the couple cases we did. And so that didn't exist when I was a trainee, right? So just these type of mediums allow us to give feedback more in real time, which is probably important, and more frequently. I think a lot of educators have thought a lot about feedback and how to deliver feedback. I think it's tricky, right? Because I don't think it's as simple as like, what is it, like the feedback sandwich, like good news, bad news, and then follow up with something good, right? I don't think it's as simple as that. But what I have found is, and maybe this is again a millennial thing or whatever, that the trainees are more receptive to feedback nowadays. They want feedback, and I think especially if you can deliver it in a constructive, nice way, they appreciate it even more.
So, Dr. Kwon, as you mentioned earlier, that the sort of all the trainees you work with, you have a very trainee-specific sort of focus towards their education and guiding them towards becoming an amazing surgeon. The landscape of surgical training has shifted a lot with simulation labs, duty hour restriction, and increasing subspecialization as well. Earlier in training, having both been in the shoes of a trainee and now someone responsible for the program here, what changes have genuinely kind of improved how we train surgeons, and what changes kind of concern you moving forward?
Yeah, I can start with the concerning things first, just to get around the top of my head. I do worry that orthopedic residency has increasingly gone to early specialization, right? Meaning if you're going to go into spine, there are more opportunities to do spine electives during your rotation, or focus your residency on what you would like to go into eventually, right? There are GMB requirements that you have to do X number of months of trauma and sports and whatnot to complete your orthopedic residency. But those are actually pretty easy to meet if you look at those requirements. So there is more elective time. I understand the arguments, but and I'm not going to say that's what fellowship is for, meaning if you want to go into spine, you do a spine fellowship. But I just worry about it in general, that trainees focusing too early on exactly what they're going to do. Now, if there was a perception and a problem that after your fellowship and subspecialty training that you were not prepared at that point, then you can make an argument that during residency you probably should be focusing more on what you're going to go into. But I don't think there's that perception or that problem. I think this also relates to the internship. So if you look at people who were older than me, generally they had 2 years of general surgery internship before starting orthopedic residency. It's 1 year, and when I was a surgical intern at MGH, I think I did about 2 months of orthopedics and the rest were general surgery. While it was challenging, I learned a lot about how to take care of patients and surgical patients on my general surgery rotations. I'm not saying I didn't learn about that on my orthopedic rotations, but because, in general surgery, you may be focusing more on multiple systems and not just the musculoskeletal system, you really were taught how to take care of patients in a more complete way, I think. Maybe that was just my experience. So I do have some concerns that the internship is even more orthopedics now. I don't quite know how many months our residents get now, but I think it's like 6 months of orthopedics. And so I think that's a little bit of a concern. But it's really hard to measure this, right? It's really hard to measure, is this producing better surgeons or worse surgeons, smarter doctors or not as smart doctors in terms of what they eventually go into. It's very hard to measure that.
I see. And when you mentioned kind of general surgery giving you a more holistic view of the patient, do you kind of mean that in sort of a more technical way, a qualitative way, both? And how does that information kind of being passed down, like almost like informally?
Yeah, I mean, I think that, at least in my experience, there was a little bit of a different rigor looking at things as related to the patient care. So when I started my internship at MGH, it was actually the last year that general surgery had a true ward service. So it was a resident-run general surgery service. there was no attending. And so the attending was Jenny Sang, who's a surgical oncologist, but she was a PGY 7, I believe, and she ran that service. And so it's a little bit historic because that doesn't exist nowadays, right? A completely resident-run service. And I started on that service. It was very busy, but everybody from the intern to the PGY 3 to the 5 to Dr. Singh knew everything about every patient throughout the day. Knew what their eyes and nose were, knew what their labs were, it was a certain amount of rigor that I learned on that service. So I think that's why that was important, and maintaining a certain amount of non-orthopedic rotations during the internship is important.
Thank you.
Yeah. On the flip side, I think that our residents are certainly more well read. I'm not sure if they're necessarily scoring higher. I don't know this literature, like on the OIT in-service training exams and on their boards and things like that. But my perception is that they're more well-read. And that may be a reflection of the changes in the work hours. Or they're just playing more golf, right? I don't know. But I think that's one thing that I have seen with the changes in the work hours. When I was a resident, I found it very hard to dive into the primary literature, aside from just the textbooks and the review books. And I think our residents are much more doing that, which I think is important. And I think the earlier you can do that in your training, probably the better it is. So,
what genuine improvements have you kind of seen from the residents being more well read?
I think you just kind of have higher level discussions about patients. I think it's important to be able to discuss some of the things that are more kind of cutting edge or controversial, or that is the newer thought process in terms of fractures or syndesmosis. I mean, our team did a lot of work on syndesmosis, right? And so the residents they know more about what some of the controversies are and the subtleties. So I think you can have a higher level discussion. It used to be in the past that with the fellows you could have that, and the residents not necessarily so much so. But I think the residents are more kind of up to date because of that.
I see. Thank you.
Yeah.
And if you think about all the residents and the fellows that have come through your service, what's the one thing that you hope that you most hope that they carry forward, specifically regarding how to be a surgeon and a teacher themselves one day?
Yeah. Even on our service, we have great educators, great mentors. I do think people have different teaching styles. Okay. I think ultimately people will revert back to what their own personality is in terms of how they treat trainees and other people. But I hope they take away how do I say this? Kind of like a thoughtful, caring teaching environment. Mm-hmm. I think more people are motivated by the carrot than the stick. Nearly everyone who goes into medicine or residency has a certain amount of intrinsic motivation to how they approach their lives. And I do think that most people who are intrinsically motivated are more motivated by the pat on the back than the stick. And so I hope that the residents and fellows that come through our service, where mainly it's a pat on the back and hug type thing, that they carry that forward. Because I think very few trainees benefit from a kind of a negative, criticism-heavy teaching environment.
Okay, and when you think about your own legacy in this department and in this program, what impact would you most like to leave?
Yeah, I have kind of conflicting thoughts on this. Honestly, conflicting thoughts on the word legacy, because I think it's almost a little bit egotistical, a little self-serving. You can look at the term legacy and how one thinks about their legacy in that way, right? I think, just taking having the job that I have, our missions are very clear and simple. right? It's to take great care of patients. It's to teach the next generation of surgeons, and it's to do research to advance the field. And it's pretty straightforward, right? So I think if I can continue that and continue that tradition, which has been a tradition of MGH and MGH orthopedics. I've been involved with MGH or Harvard Orthopaedics for, I don't know, 20 years or 20 something years. And that's been our tradition of excellence. You know, I read this in a book. It was a simple quote. It said that excellence matters. Right. And so I think it's kind of an interesting thing because it's two words, but there's a lot of implication to that. So excellence matters. So I think if I can continue on our tradition, that honestly would be enough for me. You know, I don't need to have a building named after me or, you know, a surgical technique or a metal plate named after me. In fact, that's not a good idea. So I honestly don't think too much about my legacy. I just think about making sure that those three missions that we're doing well.
Thank you. It's really insightful.
Thank you for all your genuine responses. You've now seen surgical education from every angle. As a trainee at a program that rotates across some of the best hospitals in the country, as a fellow, as an attending at an academic center, and now as a service chief overseeing the whole pipeline. If you could change one thing about how we train surgeons in this country, not just at Harvard, but across the nation, what would it be and why?
That's a tough question because I think we, as it is, do it very well. And I'm not just saying this at Harvard or MGH. I think generally speaking, most training programs do a very good job. There are obviously like requirements of a training program that probably ensures that we produce safe orthopedic surgeons. But I think generally speaking, I mean, I think most training programs do a pretty good job. I think that there is a lot more to orthopedic residency, producing great surgeons, than just learning how to fix bones and things like that. I do think a lot of the other stuff that we talk about, you know, sensitivity or empathy or dealing with difficult patients or, you know, dealing with, you know, your life outside of orthopedics is just very casual throughout the residency. There's no formal program of how to deal with everything else aside from fixing bones. And so I think that there is a opportunity in our training programs for that. You know, the first year in practice is probably the steepest learning curve for trainees who are now faculty, right? There's many reasons for that. One of the main reasons is the difference in stress level, right? You are in charge. And if a patient gets hurt, it's your fault, right? Inadvertently, but it's your fault. It's not someone else's fault. So there's a lot of, you know, emotional burden to that stress. So that's one of the main things. But also another thing is the steep learning curve is the fellows who are now first-year attendings are learning a lot of things that we didn't teach them, right? We didn't prepare them for. So I think that there's room in a surgical curriculum to formally talk about a lot of these other things about how their life is going to be. So we have Thursday night, the fellows are coming over to my house, and we're going to have pizza and beer, and we're going to talk about starting out in practice. Like, you know, what are your questions? We can tell you about our experiences. And this is probably going to be one of the most valuable sessions for them throughout the entire year. So I think we can do a better job doing that sort of thing.
Thank you.
Thank you. Everything you shared about teaching, mentorship, and what it means to build the next generation of surgeons is kind of exactly what we hope to explore today. And we're so grateful that you're doing it at MGH and right here at FARIL. It's been a great honor, Dr. Kwon.
Yeah, well, thanks for having me. It was fun.
Thank you.
Thank you
Hopefully
so
I
much.
didn't say anything too crazy.